The Medicaid billing workflow for addiction treatment has one failure point above all others. The clinical record does not support the claim, and the payer denies it. In the revenue cycle, most billing failures originate in one place. The documentation does not support the level of care or the codes being billed. The Medicaid billing workflow for addiction treatment step by step, built for treatment center operators, billers, and revenue cycle teams. We walk the revenue cycle from insurance verification through medical necessity, prior authorization, documentation, coding, submission, and denial management. Medicaid is the most variable payer category in behavioral health because each state administers its own program with its own rules. Core services run under the state plan, while many states expand coverage through 1115 waivers and 1915 waivers for managed care carve-outs. Most states carve behavioral health into a separate managed behavioral health organization, so your codes and documentation rules may differ from the physical health plan. Most prior authorization denials for residential, PHP, and IOP services come from one avoidable miss: the authorization lapsed before the next certification period. Most commercial payers require submission within 90 to 180 days. Miss the timely filing deadline and the claim becomes an uncollectible denial. The sooner a denial is appealed, the higher the recovery. Denials more than 60 days old recover at significantly lower rates. Behave Health's integrated RCM platform is designed to connect clinical documentation directly to billing, addressing the handoff errors that are the most common source of claim delays. Note, templates, and assessments are designed to capture what payers require, so the clinical record supports the level of care and the codes billed. The platform is designed to automate verification, authorization tracking, submission, and payment posting, with real-time dashboards for review. 4 front-end steps decide whether a Medicaid claim gets paid. Get these wrong, and no amount of back-end follow-up rescues the money. Verification, medical necessity, prior authorization, and coding. Let us walk all 4. Step 1. Verify insurance on every admission, not just new patients. Confirm active coverage, behavioral health benefits, in-network status, deductible, and copay or coinsurance amounts. Verify every admission, because coverage lapses between visits, and for a carve-out plan, confirm which organization actually administers the benefit. Step 2. Document medical necessity before admission. Gather clinical information sufficient to document ASAM criteria for substance use disorder cases or DSM-5 criteria for mental health. The majority of state Medicaid programs now require ASAM criteria-based documentation for level of care determinations, and it is increasingly audited. Step 3. Submit the authorization request with clinical information and track it relentlessly. Track the authorization number, service types authorized, authorized units or days, and the expiration date, and enter them into your record immediately. Most denials stem from lapsed authorizations, so set automated alerts 5 to 7 days before expiration and submit concurrent review early. Step 4. Assign codes that the documentation actually supports. Coding staff or your EHR module assign the appropriate CPT and HCPAS codes, modifiers, ICD-10 diagnoses, and place of service. All codes must be supported by documentation, or the claim is exposed on audit and at denial. Beyond the workflow, 4 Medicaid-specific rules shape what you can bill and how you document it. Medicaid rates for behavioral health typically run about 60 to 80% of Medicare rates, though some states add enhanced rates for specific services. With managed care carve-outs, where contracts, codes, and documentation requirements may differ between the behavioral health organization and the physical health plan. The Medicaid IMD exclusion blocks federal funds for facilities over 16 beds. Know your bed count and your state's 1115 waiver status for SUD treatment. Denials are worked, not written off. The denial reason tells you exactly what the back-end workflow must fix. Denials are worked immediately because the sooner a denial is appealed, the higher the recovery rate. Peer-to-peer calls between your clinical staff and the payer's reviewer overturn denials at a higher rate than written appeals alone. Behave Health connects clinical documentation to billing, so the front end and back end of the Medicaid workflow run as one system. Real-time eligibility transactions are designed to verify active coverage, deductibles, and out-of-pocket status before the patient is seen. Authorization number, approved level of care, units, and expiration date are designed to live in the record with automated alerts. Pre-submission scrubbing and denial dashboards are designed to catch errors before submission and surface patterns by payer and denial code. Stop losing Medicaid claims to documentation gaps and lapsed authorizations. Book a 20-minute demo at behavehealth.com. See verification, authorization tracking, and denial analytics built for behavioral health billing at behavehealth.com.